everyone, so thanks for joining in to another episode on PharmD&ME. Today we're going to be discussing a very common health issue that affects many of our patients today, and that is dyslipidemia. So before we get started talking about the guidelines, I just want to take a moment to go over the lab values. Although the guidelines today don't really emphasize getting target lab value goals and achieving certain numbers, I think it's still good to have a baseline knowledge. So first, let's talk about total cholesterol. We want a total cholesterol goal of less than 200 milligrams per deciliter. We want an LDL of less than 100. We want to have our HDL be at least 60. And we want to have our triglycerides ideally less than 150. So the guidelines recommend that our patients that are at least 20 years of age get a fasting lipid panel every 5 years. Now, let's take a moment to talk about our gold choice, our treatment of choice, our gold standard for dyslipidemia, and that is statins. Now, statins are a little bit controversial due to their side effects, but the reasons that they're so good is that they reduce the LDL anywhere from 20 to 55%, and they reduce both cardiovascular and all-cause mortality. Additionally, something important to know is that they recommend monotherapy when you prescribe a statin. The reason for this is that they've done studies and found that when you start adding on other lipid-lowering agents, it actually increases the risk for adverse events. So let's take a moment now to discuss the 4 statin benefit groups outlined in the guidelines. So the top benefit group here we see is clinical ASCVD. Clinical ASCVD is the only statin benefit group that is for secondary prevention. So if you'll think back, ASCVD stands for atherosclerotic cardiovascular disease. So these are things such as acute coronary syndromes, having a history of an MI, stable or unstable angina, coronary or other arterial revascularization, having a stroke, a TIA, or peripheral artery disease. So basically, your patient's had a bad cardiovascular event in the past, you want to try to prevent it. Give them a statin. Second benefit group here we see is pretty self-explanatory. If your LDL is at least 190, you are a candidate for a statin. The other 2 benefit groups are a little trickier, so let's take a moment to go over them. This third one here is just your average, patient, 40 to 75, pretty normal LDL, never had an ASCVD, but they're diabetic. So your diabetic patients that meet the other criteria are a candidate for statins. The last benefit group, again, just a regular old 40 to 75-year-old with pretty normal LDL, never had ASCVD or diabetes, but they have a 10-year ASCVD risk of at least 7.5%, they are a candidate for statins as well. And if you remember, the American College of Cardiology came out with an ASCVD risk calculator, and they actually have an app for it, so if you don't have it on your phone, I highly recommend it. But basically the things it looks at when they calculate that percentage are the gender, the race of the patient, their age, their smoking history, their HDL level, their total cholesterol, their diagnosis of diabetes, whether they're being treated for hypertension, and their systolic blood pressure. So now that we've talked about the statin benefit groups, let's just take a moment to go over the statin intensities. So depending on the agent and the dose, you have high, moderate, and low intensity statins. Your high intensity statins are your atorvastatin and your Crestor, and they reduce your LDL by at least 50%. Your moderate intensity statins reduce your LDL by 30 to 50%, whereas your low intensity statins reduce your LDL by 30%. So, who's a candidate for a high intensity statin? Well, if you are a patient that has clinical ASCVD, so you're in that first statin benefit group. If your LDL is at least 190, so you're in the second statin benefit group. Or if you're diabetic with an estimated 10-year ASCVD risk of at least 7.5%, you're also a candidate for a high intensity statin. So who is a candidate for a moderate intensity statin? Well, if you have clinical ASCVD but you're over age 75, you're actually a candidate for moderate intensity just due to the fact that you're older, you're at greater risk for myopathy and other side effects. So you kind of want to balance that risk versus benefit ratio. The other patient that's a candidate for moderate intensity statin are diabetics who have a 10-year ASCVD risk of less than 7.5%. So now let's take a moment to discuss statins a little bit further. So what are their side effects? Well, they're generally well tolerated, but the most common side effects are things such as headache, insomnia, dyspepsia, and then just your typical, constipation, diarrhea. Something that's important to note is that 5 to 10% of patients develop myopathy. Or, excuse me, myalgia rather. An increased risk of rhabdomyolysis is also possible, especially if you have a drug interaction. So if you're taking it with a CYP3A4 inhibitor, you're at increased risk for myopathy, or if you take it with a fibrate, because fibrates already put you at an increased risk of myopathy. So that's when they say the whole monotherapy thing, that's partly due to your side effects. So what are the contraindications? Well, it is a category X for pregnancy. So do not take if the patient is pregnant or may become pregnant. Additionally, active liver disease is a contraindication. How should you monitor this drug? Well, you want to monitor it by obtaining a fasting lipid panel 4 to 12 weeks after initiation. And then you're going to want to monitor every 3 to 12 months thereafter. You can get a baseline creatine kinase level if you have a high-risk individual who's at high risk for myopathy, so maybe if they already come in with some muscle issues. And then just a clinical pearl. Oops. If you get 2 consecutive LDL readings, less than 40, consider dropping the dose down, because you do want to have some LDL in your body, obviously. So now we're going to consider the other classes of agents that are available to treat dyslipidemia, and they are niacin, bile acid sequestrants, omega-3 fatty acids, fibrates, and cholesterol absorption inhibitors. So, niacin is a B complex vitamin, and it works by preventing the formation of LDL in your body. Some common side effects from niacin include flushing, and you can counsel your patient to take an aspirin 325 milligrams about 30 minutes prior to reduce it, but it should go away with time. Other side effects include headache and syncope, and some report that it can cause some GI upset. You should monitor your LFTs, uric acid, and your glucose/A1C at baseline, during dose titration, and every 6 months. Absolute contraindications include active liver disease, again, like we saw with statins, active peptic ulcer disease, arterial bleeding, and unexplained LFT elevations. So now that we've talked about niacin, let's go on to our next class, which is the bile acid sequestrants. Some examples of these are Colcevalam, brand name Welchol, and Sevelamer, brand name Revella. There are others, but I'll just mention those two. So these agents basically work in the gut to bind bile acids that contain cholesterol and prevent their reabsorption. So they basically flush the bile acids out. When it does that, your liver is forced to use its own cholesterol to make more bile, thus lowering the cholesterol in your blood. So some side effects to be aware of with these agents are primarily GI. So it can cause some constipation, nausea and vomiting, dyspepsia, bloating, and flatulence. Contraindications to use are actually a triglyceride greater than 500, because I'm going to show you at the chart at the end of this video, it really doesn't affect your triglycerides much. History of bowel or biliary obstruction. And then again, a history of hypertriglyceridemia-induced pancreatitis, just because it really doesn't touch your triglycerides. So some pearls. This class is actually pretty interesting. So Welchol, your Colcevalam, is actually approved for type 2 diabetes. And that's because bile acid sequestrants lower your fasting glucose and A1C. So if you've got a patient that's diabetic and struggling with their lipid levels, this is a really great agent to consider. Additionally, bile acid sequestrants interfere with the absorption not only of fat, but also fat-soluble vitamins. So if you've got a patient with some weird symptoms, perhaps related to deficiency in nutrients, consider maybe they're not getting all their fat-soluble vitamins. So now that we've discussed bile acid sequestrants, let's take a moment to go over the omega-3 fatty acids. And the two agents in this class are Lobasa and Vascepa. So the active lipid-lowering components of fish oil that offer the cardioprotective effects are known as EPA and DHA. Now, omega-3 fatty acids can also be used for coronary heart disease, but the recommended daily dose for that is 1 gram. If your patient is using it for dyslipidemia, you want to make sure that they're getting a 3 to 4 gram dose. So if your patient walks in with a 1 gram prescription and they think they're getting it for their triglycerides, tell them you might want to consider calling the doctor and double checking on that. Some side effects to be aware of. It is fairly well tolerated, but some patients report taste perversions. Belching, some people say that it kind of gives them a fishy taste. And then it can cause some GI disturbances. Another clinical pearl is that it is approved for the treatment of triglycerides greater than 500 in adults. Alright, so that covers the omega-3s. Now we're going to move on and talk about our fibrates. So this class has two agents again, and they are fenofibrate and gemfibrozil. So These work by reducing hepatic apoprotein synthesis, thus lowering triglycerides and increasing a patient's HDL. So, side effects for these agents, again, transient GI. But what makes them unique is that they can actually increase your creatinine and your LFTs. Additionally, they can cause gallstones, and myopathy. So thinking back to statins, I said, don't use a statin and a fibrate because of the increased risk of myopathy. As far as drug interactions go, something again that is unique with this, a Pearl, is that they increase prothrombin time. So use them with caution in patients on warfarin. Contraindications to this drug include gallbladder disease, which makes sense with the risk of gallstones, hepatic dysfunction, which makes sense with the risk of elevated LFTs, and severe renal impairment, which again makes sense when you think back to the side effects. So you're going to want to monitor, because of this, you're going to want to monitor your CBC periodically, first year. And then each agent has different monitoring parameters. So for your fenofibrate, you want to monitor your LFTs periodically. And then you want to monitor your renal function at baseline, 3 months, and then every 6 months. For the gemfibrozil, though, you just want to monitor your LFTs every 3 months, first year, then periodically. So, some differences there just to be aware of. Our last class that we're going to talk about are the cholesterol absorption inhibitors. And in this class, there's only one agent, so that is awesome. And that is your Zetia. So Zetia works by inhibiting the absorption of dietary cholesterol at the brush border of your small intestine. So if your body can't absorb it, just gets flushed right on out. It is approved as monotherapy or in combo with a statin or fenofibrate. Side effects. Again, it's pretty well tolerated, but it can cause some unique ones. So it can cause upper respiratory tract infections, arthralgias, fatigue, myalgia, and diarrhea. Contraindications are patients with moderate to severe hepatic disease. As far as pearls go, if you're on a statin plus Zetia, more likely to have increased LFTs. So monitoring LFTs then is recommended. All right, so that pretty much covers it. Just a couple kind of pearls to throw out to here that I didn't get to discuss earlier is final pearls. If your patient has a triglyceride greater than 100, the following agents are approved. So niacin, fish oil, gemfibrozil, and if you have a peds patient, you can use a statin or bile acid sequestrant for hyperlipidemia in children. So that pretty much covers it. I'm just going to leave you here with this chart that I developed here so you can kind of get an idea in your head by how much each of these agents is going to decrease your cholesterol. So I hope you all enjoyed this video. If you have any comments, please leave them in the comment section below. We'd love to hear back from you, what you liked, what you didn't like, and happy studying.